Hello everyone, my name is Maria. Today we will go through the treatment of osteoporosis pharmacology lecture. Inshallah it will be useful. So to begin with, what osteoporosis is? Osteoporosis characterized by progressive loss of the bone mass and skeletal fragility. So as you can see in this picture, we have the normal bone and the osteoporotic bone, and we can see that osteoporotic bone is porous, fragile, and more susceptible to fractures than the normal one. So who is at risk of getting osteoporosis? Old people and mostly postmenopausal women, and that's because of the drop that happens to the estrogen levels. And why is estrogen important? So basically we have osteoblasts and osteoclasts. Okay, osteoclasts are bone crushers and osteoblasts are bone builders. Okay, so estrogen, when it is present, it will inhibit the crushers of the bone. So when the menstrual cycle stops and the estrogen levels drop, there will be no one to inhibit the osteoclasts, so their activity will be increased. Okay, and then we have also cancer patients at the risk of getting osteoporosis. Why is that? Because, for example, when the cancer or metastasis gets into the bone, they will weaken the bone. Okay, and also certain drugs like glucocorticoids and cortisone enhance the activity of the crushers of the bone, which will cause osteoporosis. So as we said, we have osteoblasts and osteoclasts, builders and crushers. Okay, so our bone is at the state of remodeling. So we will always have osteoblast and osteoclast. Both of them are important. Tamam. Osteoblast activity is maintained by or enhanced by hormone called calcitonin, which is released from the thyroid gland, whereas parathyroid hormone will enhance the activity of osteoclasts. So we have hormone for osteoblast and osteoclast, and it's important to understand this because it will help us to understand the pharmacological strategies later on. And I would like to stress on that estrogen has no effect on osteoblasts. As we said, estrogen is related to inhibition of osteoclasts and not activation of osteoblasts. Okay, so estrogen just inhibits the osteoclast, okay, and no relation to osteoblast. Okay, so how we treat osteoporosis? We have two approaches or strategies. The first one is non-pharmacological, is maintaining adequate dietary intake of calcium and vitamin D. Why is vitamin D? Because vitamin D is what will help our bones to absorb calcium. Okay, also we have weight-bearing exercise, smoking cessation, because again nicotine is what stimulate osteoclasts, which are the crushers of the bone, and also avoiding drugs that increase bone loss. So if the patient is taking cortisone, for example, they should stop it in order to treat osteoporosis. And then we have pharmacological strategy, and we will discuss them one by one. We have bisphosphonates, selective estrogen receptor modulators, calcitonin, denosumab, and teriparatide. Okay, so we need to understand this bone remodeling cycle before we get into the drugs. Okay, so as I said, we have osteoclasts and osteoblasts. Okay, هلا osteoclast لما يكونوا differentiated, they are look like macrophages. They have this type of extensions. They are multinucleated, and they are here to digest the bone. On the other hand, osteoblasts here, they are not multinucleated. They will form the osteoid that will be mineralized with calcium and phosphate and form as hydroxyapatite, which is needed and will be deposited in the bone. Okay, so to begin with, the class bisphosphonates. Bisphosphonates, we have 7 drugs, and these 7 drugs will focus on decreasing the osteoclast activity. When are they used? They are used to prevent and treat postmenopausal osteoporosis. They are used for Paget's disease, to treat bone metastasis in malignancy, and hypercalcemia. So for example, a patient has breast cancer and the metastasis of this malignant tumor got into the bones of the patient. Here the patient can be described bisphosphonates to strengthen the bones, right? So in this mnemonic, bispho, B for bone metastasis, P for Paget's disease, which is a chronic disease that is characterized by weak bone, H for hypercalcemia, and O for osteoporosis. Okay, so now we have the mechanism of action. We have simple compounds like etidronate that look like pyrophosphate. As you can see, they are so similar structurally. So what happens here, لما etidronate gets to the bone, the osteoclasts are getting so happy, so excited, they start taking up this etidronate. They think that this is their ATP precursor. Then they realize this is not ATP, we got tricked, and then they undergo apoptosis. And also we have amino bisphosphonates like pamidronate, arendronate, risidronate, zoledronate, and ibandronate. Okay, so these drugs will interfere with cholesterol biosynthetic pathway that will interfere with attachment of osteoclasts to the bones. So as you can see here, either we are killing these osteoclasts by, for example, etidronate, or we are not allowing these osteoclasts by interfering with their cholesterol biosynthetic pathway and will not allow these osteoclasts to attach to the bones. So we will have not functional osteoclasts. Okay, by what? By amino bisphosphonates. Okay, then we have the administration of the drugs. We have arendronate, ibandronate, and risidronate. They are taken orally, and also ibandronate can be taken IV, as well as zoledronic acid or zoledronate. So to memorize what drugs are taken orally, there is the mnemonic Alen's band rises to fame. Alen's for arendronate, band for ibandronate, and rise for risidronate. Okay, and IV drugs are taken less frequently than the orally administered drugs. Okay, so here we have that the IV drugs, ibandronate and zoledronic acid or zoledronate, can be used to reduce the incidence of skeletal-related events and bone pain in the patients with cancer. Both of them can be used for this. And for zoledronic acid, it can be used as a support medication to treat symptoms of cancer such as hypercalcemia, and also to decrease the complications, as we said. Okay, so now for the guidelines of taking bisphosphonates, they should be taken with 6 to 8 ounces of plain water only, which is approximately 150 to 250 milliliters of water, taken at least 30 minutes before meals or medications, except for risidronate that will be taken immediately after breakfast, and ibandronate, it is taken 60 minutes before the meals or any other medications, and the patient should remain upright and do not lie down or recline for at least 30 minutes. That will help the gastric movements for faster absorption. And again, except for ibandronate, the patient will stay upright for 60 minutes. And you need to know that bisphosphonates are eliminated renally. So in case of renal failure, you cannot prescribe bisphosphonates. And bisphosphonates are rapidly cleared from the plasma because they bind to hydroxyapatite rapidly. Okay, so now the adverse effects of bisphosphonates, we have GI related. So for example, diarrhea, abdominal pain, esophagitis, and esophageal ulcers. Also, there is something called bisphosphonates-related osteonecrotic jaw, which is mucosal ulceration and exposure of underlying necrotic bone. Okay, and MSK-related effects, musculoskeletal pain, atypical fractures, and osteomalacia. Okay, osteomalacia is when the bones are weakened because of the lack of vitamin D. So here we have another class, which is selective estrogen receptor modulators, raloxifene. So as we said, in case of postmenopausal women, the levels of estrogen will drop and the osteoclast activity will be more and more. Okay, so we don't want to do estrogen replacement therapy in this case, because estrogen has another disadvantages, or in this case it will cause her breast cancer or endometrial cancer, as well as venous thromboembolism and stroke. So what we do is that we apply or use this drug, okay, that is estrogen agonist on the bone and antagonist on the breast and endometrial tissue. And this will be alternative for postmenopausal osteoporosis in women who are intolerant to bisphosphonates. Okay, and as we said, this will not cause her endometrial cancer or breast cancer. And also it will reduce the levels of low density lipoprotein cholesterol, which is the bad cholesterol, which is good. Okay, and adverse effects of this drug: hot flashes, leg cramps, and risk of venous thromboembolism, the one that will happen or could happen if you do estrogen replacement therapy. Then we have calcitonin. Here we will use salmon calcitonin, and remember with calcitonin, the nose. So this drug can be either applied intranasally or parenterally. And also, talking about the nose, one of adverse effects is rhinitis or other nasal symptoms. And this drug will reduce bone resorption, so again it will act on osteoclasts, but it is less effective than the bisphosphonates. And the unique property of the calcitonin is that it relieves the pain which is associated with osteoporotic fracture. Okay, then we have denosumab, which is, we can say, a clone for antibody. Basically, what happens here, we have denosumab, okay? This denosumab will go and take a rank ligand. Rank ligand is a receptor activator of nuclear factor kappa B, I guess, yes. Okay, and take it. Why? When this denosumab will take rank ligand, this rank ligand will not be able to attach to rank which is present on the osteoclast. So osteoclasts, they have rank that needs to be attached to rank ligand to be activated. Then comes denosumab and takes this rank ligand, and then there will be no attachment for the osteoclast and then no activation of osteoclast. So again, denosumab acts on osteoclast. Okay, and it is applied subcutaneously every 6 months, and it is approved for the treatment of postmenopausal women at high risk of fracture, and it has been associated with increased risk of infections because it is acting on antibodies, okay, or it inhibits a lot of immune mediators. Okay, also dermatological reactions since it's applied or injected subcutaneously, hypocalcemia, osteonecrosis of the jaw, and atypical fractures. Okay, then we have lastly the teriparatide, which is the only drug that we are discussing here will act or will activate the osteoblasts, okay? And it is a recombinant form of human parathyroid hormone, but only consists of 34 active amino acids of the hormone, okay? And it is administered subcutaneously daily for the treatment of osteoporosis. And it will be reserved for patients at high risk of fractures and those who have failed or cannot tolerate any other therapy, because it's like it's not that easy to synthesize it. And yeah, I think that's it. Thank you for watching.